Thank all the postgraduates and for their excellent presentation, and I also thank the chairpersons for their contributions. I'll also request the chairpersons to hand over the certificate of appreciation to the presenters. I'll request Dr. Ravi to do the honors as well. Dr. C.B. Chakravarti, who presented the first case. Dr. Niroj Kumar from MMC. Dr. Arvind Manohar, Gleneagles.
Dr. Ganesh,
Dr. Sai Praneeth from KMC, please.
so Dr. Barnabas,
Start with the secretary report. Just a minute till the computer loads. I think it's heartening to see more postgraduates attending this time, so I hope they also come in time for their postgraduate session. I think the first 1.5 hours is mainly towards the postgraduates. I'll request all the postgraduates to be in time, be here by around 5:25, 5:30, so that we can start the session in time. So first thing towards the society is that with help of all the society members, we have got the GST registration. We discussed about this at the annual meeting, so it has been registered in the GST. So we have a GST number now. So that was one of the prerequisites for applying for our ISG, for applying for any ISG meeting nowadays. So we've got that now. The 10th ECME was conducted successfully on 20th March. I thank Professor Kandasamy and his team from Tirunelveli Medical College for coordinating the session. About 55 members attended, and I earnestly request all the postgraduates to log in. It's only an ECME. Again, the idea is to give chance to the postgraduates who not have an opportunity to present in this forum here in Chennai. So I again request all the postgraduates to log in and benefit from this ECMEs. The research project that is about to be winding up now in this month will be the Tamil Nadu ISG HCC study. It's in the data collection phase. I think in a couple of days it will be the last day for data collection, and then subsequently they should be able to submit their data for further analysis. And hopefully in the next 3 to 6 months we should see a publication or a submission from this going on to one of the leading journals. The next proposed study is a research project is objective phenotyping of symptom-defined GERD, a multi-center study from South India, where Dr. Elvarsi will be the principal investigator. I think about 25 centers have shown interest. It will be to look at objective evidence of GERD based on endoscopy or ambulatory reflex monitoring, either by pH study, along with pH study, to see what proportion of patients who are positive for a symptom questionnaire actually have a GERD. I think it is in the phase of statistical review, and hopefully in the next month or so we should be able to get send it across for institutional ethics committee clearance from all the centers, and in a couple of months hope to start the study across all the centers. I'll request and welcome all members to attend the inauguration program of the Colitis and Crohn's Foundation program, state chapter inauguration program tomorrow. It will be in the same hotel, in the first floor. It will be from 8 to 1:30, 8 to 9 will be a breakfast and registration, and followed by a program which starts at 9:30 and goes on till 1:30, followed by lunch. So I'll request all of you to also make time to attend on a Sunday morning, but it's packed with good lectures and panel discussions also. And also, I think we have already circulated the live membership Excel file with the numbers. Any omissions or any corrections, kindly send a note to secretary@tnisg@gmail.com in the next 2 days so that I can incorporate that, and we'll upload the final version the next month. And to all the postgraduate members, I request you, some of you have filled up an Excel sheet and Google sheet and sent across to me, but that alone is not enough. I would request you to go to your Tamil Nadu ISG website and register and apply as a student member. So this will be a temporary membership for about 3 years, and after which in 3 years' time you will move out. I mean, depends on if you are going to stay back in Tamil Nadu and practice, I would request you to reapply as a life member after you finish your course. So the PG course is just a very nominal fee, so 500 rupees for your membership. I think you should all be able to do, and I hope that all of the remaining members will be able to enroll in the next month. And also, please enroll as a member of the National Society also. And last but not the least, please scan your QR code in front of you on your table, so that will help fill up the digital attendance as well. And now we'll move on to the CMA section. I request the chairpersons, Dr. Ganesh and Dr. Sumati, to come over and conduct the proceedings, please.
Good evening, everyone. There is a slight change in the program as Dr. V.G. Mohan Prasad sir is on the way. I think next speaker will be Dr. Gokul from MedIndia, who is a senior consultant. Hard to lose, newer pharmacological treatment in management of constipation. How to optimize. Dr. Gokul, please. He needs no introduction to this august audience.
Respected chairpersons, my dear teachers and friends, good evening to you all. First of all, I'd like to thank the TNISG for giving me this opportunity. I bring warm greeting from MedIndia hospitals. The topic given is newer pharmacological treatment of constipation and how do we optimize treatment. Now, the scheme of my talk is to tell you something about the types of constipation, the prevalence, the treatment goals, stepwise approach which we commonly follow, the drugs available, and how to optimize treatment. Now, we are all aware of the fact that secondary constipation only constitutes 10 to 15%, whereas primary constitutes the majority of the constipation. You know the subtypes, the normal transit, the slow transit, and the defecative disorders. We also have one other subtype of functional GI disorders, which is IBS constipation. Coming to the prevalence of constipation, the functional constipation or the chronic idiopathic constipation, both are interchangeably used. The prevalence is 17%, it is higher in women, and it gradually rises with increasing age. IBS, again, the overall prevalence is 8 to 11% global, but it is slightly less in India, 4 to 6%, of which IBS constipation is one subtype, but seems to be the least common subtype. It comes after IBS mixed type and the diarrheal type. Younger females, again, are more commonly affected because of this. Now, coming to treatment goals, in a patient who receives treatment for constipation, our idea is to increase the frequency of what is called spontaneous bowel movement, which is defined as that which occurs without the use of laxatives in the preceding 24 hours. Again, one more addition to this is what is called complete spontaneous bowel movement, where the patient also has the satisfaction of having emptied his bowel completely. Then there is also a decrease in severity of abdominal pain or discomfort that should accompany the bowel movement. And this is again very important in treating a patient with irritable bowel syndrome. The third one is to improve the overall quality of life. The stepwise approach which we commonly follow in our clinical practice is given here. So we usually start with dietary fiber supplementation. Then we move on to the osmotic laxatives, which is typically polyethylene glycol or lactulose. And then we use stimulant laxatives as a rescue treatment or a very short-term treatment, like less than 4 weeks duration. And if this fails, then we go to a prokinetic or a secretagogue or use a combination of these drugs. Coming to treatment of IBS constipation subtype, again, lifestyle and dietary measures has to be emphasized. Here there is less emphasis on fiber. Fiber also helps in patients with IBS, but then these patients have bloating or pain as a predominant symptom, and therefore fiber has to be introduced very gradually, and it should be a soluble fiber rather than insoluble fiber. Again, the next step is to go to osmotics, secretagogues, and adjunctive therapy. So adjunctive therapy, I mean, is where we use a visceral sensory modulator or a cognitive behavioral therapy, etc. Drugs for constipation could be a first-line drug like fiber osmotic agents or stimulant, or the second line or the newer drugs, which includes an enterokinetic prucalopride, secretagogues like lubiprostone, linaclotide and plecanatide, or bile acid modulators like elobixibat. We don't have this sodium hydrogen inhibitor, which is tenapanor, available in India. Coming to fiber, we generally start low, go slow, and add water. Typically used for milder forms of constipation. A soluble fiber is better tolerated by patients compared to insoluble fiber, and we have very good evidence for the psyllium, or what we call isfagula. The dose has to be started very low. It is typically 3 to 5 grams per day, and then we gradually up titrate every 1 to 2 weeks until we reach a maximum dose of 10 to 20 grams. This is done to prevent bloating, and this is very important in treating IBS subtype. We need to assess response in 4 to 6 weeks before deeming the drug as an ineffective drug. Adequate hydration is very important while giving fiber, because otherwise the stool can become very hard and it can lead to impaction. Going to osmotic agents, PEG has got the great, as far as all the osmotic agents are concerned, we have very good evidence to say that it is very effective agent. The dose of 17 grams per day up to 34 grams, either as a single dose after dinner or as a split dose, is very safe. It is minimally absorbed and doesn't cause electrolyte imbalance. It's a first-line agent advocated by ACG and AGA, safe for long-term use, safe in elderly, safe in pregnancy, and also in pediatric populations. Again, lactulose is very effective drug at 15 to 45 ml per day, either as a single or split doses. But the problem is it causes fermentation-related intolerance in the form of gas and bloating. But it has got an added advantage in patients with cirrhotics, especially in hepatic encephalopathy, where it treats both constipation and hepatic encephalopathy. It is safe in pregnancy as well. Lactitol is a very similar drug to lactulose, but it has got less side effects as an alternative to lactulose. Magnesium hydroxide, which is available as milk of magnesia, is also helpful for short-term use, typically avoided in patients with CKD and elderly patients. Stimulant laxatives, helpful for rescue therapy or for short-term therapy if patient has not responded to osmotic or as an add-on therapy. Bisacodyl or sodium picosulfate at 5 to 10 milligram HS, very effective drug. The only problem is abdominal cramps. And the Senna is also a stimulant laxative, which is available as 8.6 to 17.2 milligrams per day. Again, the problem with all stimulant laxatives is because it can cause cramps. One other indication is an opioid-induced constipation with this drug is found to be very helpful. Going to the second line agents, before going to the drug, we'll see a lot of postgraduates here. I thought I would ask a question. So which of the following patients is most likely to benefit from prucalopride over a secretagogue? Is it option A, young female with bloating predominant IBS, B, elderly male with slow transit constipation and infrequent urge, C, middle-aged woman with opioid-induced constipation, and D, patient with dyssynergic defecation? So any takers for option A? Option B? Option C? And option D. So typically a slow transit constipation is the answer. Coming to prucalopride, this drug acts on the 5-HT4 receptors. It is an agonist, and this causes release of acetylcholine in the nerve terminals of the enteric neurons, and thereby the peristalsis is enhanced. Typically, the high amplitude peristaltic contraction of the colon is enhanced, and that is why it has got a prokinetic or enterokinetic action. As an indirect benefit, this drug also acts on the enterochromaffin cells and releases serotonin, which again causes secretion of sodium and water into the lumen and helps in constipation. The onset of action is 1 to 2 days, indicated in chronic idiopathic constipation, especially the slow transit type. The dose is 2 milligrams in adults. The dose has to be reduced to 1 milligram in patient who is more than 65 years, and also those with patient with CKD with eGFR of less than 30. The prominent adverse events is headache, which happens in the first few days because of its serotonin enhancing action, because it can cause migraine-like headache in some people. Coming to the next question for the postgraduates, which of the following drugs improves abdominal pain in IBS constipation independent of its laxative effect? Option A, polyethylene glycol. Option B, prucalopride. C, linaclotide. And D, lactulose. So any takers for option A? Option B? Option C? A lot of hands. And option D. Okay, so let us come to the secretagogues. The first secretagogue I'm going to discuss is lubiprostone, which acts on the chloride channels present in the apical membranes of the enterocytes. It causes secretion of chloride and draws in water and thereby helps in constipation. The onset is typically 1 to 2 days. It's indicated for both chronic idiopathic constipation and IBS subtype. The dosage is twice daily, 24 micrograms if it is functional constipation or 8 micrograms if it is IBS. Drug has to be taken after meals. This is typically to reduce the nausea which happens with this drug. This is a prostaglandin analog. So, coming to the next drug, linaclotide and plecanatide. Both drugs act similar manner. So, it acts on the guanylyl cyclase receptor protein on the apical membrane of the enterocytes. It enhances the production of cyclic GMP within the cells. And this cyclic GMP has got two actions. One, it acts on the CFTR, that is the cystic fibrosis transmembrane conductance regulator channel, thereby enhances secretion of chloride and bicarb, thereby causes hydration of stools. The second important action is it acts on the nociceptors of the terminal endings of the enteric neurons and reduces pain transmission. So this is an advantage in patients who have got IBS. Linaclotide typically acts within 24 hours, indicated for both CIC and IBS constipation. This is the only secretagogue approved for treatment of functional constipation in children between the age of 6 and 17. The dose in idiopathic constipation is 145 micrograms once daily. For IBS, it is 290. And for functional constipation in children, it is 72. The drug has to be taken before meals, otherwise troublesome diarrhea can happen. Plecanatide also has got a similar action. It is indicated for both chronic idiopathic constipation and IBS subtype. The dosage for both is 3 milligrams. Can be taken with or without food. This is an advantage compared to linaclotide. And diarrhea can also happen, but it is less common with this drug compared to linaclotide because this acts as a pH-dependent manner compared to linaclotide, which acts in a pH-independent action. So it has got action throughout the bowel. So diarrhea is a more prominent side effect of linaclotide compared to plecanatide. Coming to bile acid modulators, so this drug elobixibat acts on the ileal bile acid transporter or the ASBT and prevents the absorption of bile acids. This bile acids draws in more sodium and water into the lumen, thereby causing hydration of stool. It also acts on the Takeda G receptor 5, which is present in the apical membrane, and this causes a release of 5-hydroxytryptamine or serotonin, and this causes more fluid secretion. So it got dual action. It also has action on the colonic motility. The onset of action is within 24 hours, and typically the dose is 10 milligram once daily, taken before breakfast or dinner. The side effect is it can cause cramps. Now coming to optimizing treatment. There are few points which I managed to gather from the internet and few on my own which I thought would be helpful. I welcome suggestions and expert comments from the chairpersons and also the seniors present here. Number one, it is better to match the drug to the pathophysiologic phenotype. For example, when the patient says he has got hard stools, that means the stool hydration is impaired. So in such a situation, dry stools need fluid and not force. So in this situation, can we add a drug like an osmotic drug or a secretagogue, which can hydrate the stools better? Similarly, in a slow transit constipation, patients has bowel movements once or twice a week. So in such a situation where we want enhanced colonic motility, a drug like prucalopride will be helpful. In a patient who has got pain as a symptom, like in IBS constipation subtype, the drug secretagogues linaclotide and plecanatide has got an action on the terminal nerve endings. It reduces pain perception. So these two drugs could be helpful. And for opioid-induced constipation, which is typically receptor-mediated, the mu opioid receptors has got peripheral and central action. The central action is reduce pain perception, and the peripheral action can cause constipation. So in such a scenario, it is better to treat the receptor and not the stool. So any amount of osmotic drug or a or enterokinetic drug may not be helpful. Here, we may have to use Pamoras. Pamoras are peripherally acting mu opioid receptor antagonists, which are typically used to treat the side effects occurring because of opioids. Number 2, ensure that there is a failure of first-line therapy before escalating or going or switching to a different drug. So make sure that the patient is getting adequate dose of the drug and for adequate duration. For example, if it is going to be a fiber, it should be 20 to 30 grams as a maximum dose. And for PEG, it is a maximum of 34 grams. And typically, these two drugs can be tried for at least 4 weeks before coming to a conclusion that these drugs are not effective. Sometimes a slight tweaking of the dose can be helpful. For example, a PEG can be given as twice daily dosing instead of dinner dosing. And as a stimulant, addition of a stimulant and laxative for a short duration can be very helpful if PEG alone is insufficient or an osmotic agent alone is insufficient. Addressing modifiable factors. So many a time we forget to tell the lifestyle changes which the patient should follow. Like fluid intake is very important when the patient is taking fiber. At least 250 ml of water should be taken along with fiber intake. Number 2, total intake of fluid must be around 2 liters at least per day. Patients should have physical activity because this has been shown to promote colonic motility. So aerobic exercises, yoga or a simple walking can be very beneficial, especially in a patient who is sedentary. Number 2, it is very important to exclude dysynergic defecation by a proper history taking and evaluation because biofeedback is the only answer. Any amount of drug may not work. Review the medication. Many a time patient may be taking drug which can cause constipation, typically calcium channel blockers, opioids, antipsychotic drugs or iron. So make sure that you switch to a different drug or reduce the dose or use specific agents like Pamoras. Now combining therapy instead of early switching. So when the patient comes, our tendency is to use a drug which the patient has not tried earlier. But what we can do is, if the patient has been taking a PEG, then can we add a fiber or a stimulant to it? Already there is a combination which is available in the market. Like we have a combination of fiber and PEG, we have a combination of PEG and stimulant laxative, etc. So try drugs combination which has got 2 different modes of action. For example, osmotic improves stool hydration and a stimulant or a prokinetic drug enhances the colonic propulsion. So we can advantageously combine these 2. Similarly, a secretagogue can be combined with a prucalopride. Anticipate and manage adverse events proactively. Now, it is better, this promotes better adherence and fewer dropouts. Expect what the patient, tell the patient what he can expect after in the first few days of treatment. For example, when a patient was taking secretagogues, the initial few days of diarrhea can happen. So make sure the patient is taking the drug at the proper time and a proper dose. Prucalopride can cause headache because of the effect of serotonin. So initial few days it wanes off gradually. Lubiprostone can cause nausea, so it is better to take the drug with food instead of taking on empty stomach. Elobixibad can cause abdominal cramps at least for the first few days. So if you tell these patient can expect these things and manage accordingly. Sometimes a mechanism-based positioning also helps. For example, as a first-line drug or drug treatment in elderly or pregnancy, an osmotic laxative like PEG or lactulose is very safe and found to be helpful. As a rescue therapy, in patients who have not responded to osmotics, a short course of stimulant laxatives can be helpful. Similarly, a refractory patient or a IBS constipation, secretagogues can have added benefit of reducing pain perception. In slow transit, prucalopride with enterokinetic action can be very helpful. And similarly, in a certain subset of patients with idiopathic constipation where there is a reduced amount of bile acids in the colon, elobixibad can be very helpful. So this is how I thought we can optimize the treatment. Thank you very much.
Thank you, Gokul. That was a wonderful cover-up of all patients, how to manage them according to the phenotypes and all that would have benefited the postgraduates. The seniors can contribute.
Regarding the fiber, which is present in the cereals, the mechanism of action is undigested cell wall. It absorbs the water and increases the fecal volume or fecal. And another thing is these fruits, that is legumes and the citrus fruits. They increases the increase the growth of the bacteria and they increases the colonic volume. So these are the two different modes of action of the fibers. And another important difference between the bisacodyl and sodium picosulfate. Bisacodyl is hydrolyzed by the intestinal enzymes present in the intestines. So it will act over the small bowel as well as the large bowel. Whereas this sodium picosulfate will be hydrolyzed in the colon by the colonic bacteria. So the sodium picosulfate action is unpredictable. Depending upon the presence of bacteria in the colon, it will act, or sometimes it may not act also. And another thing is drugs producing constipation. Common drug, that is a paracetamol. If you take paracetamol 7 tablets in a week, you will have constipation. That points you have to remember. And other drugs which are usually, but you didn't mention it, colchicine and misoprostol, and these are the 2 drugs they also tried for the constipation. And what about this botulinum toxin injection in the puborectalis muscle for constipation? And vibrating capsules for the constipation.
Yes, sir. So Botox toxin can be helpful in patients with dyssynergic defecation where there is a tight sphincter. So that has been tried for a few patients. Regarding vibrating capsule, I thought of mentioning, but there is a non-pharmacological treatment, so I didn't mention. So typically the capsule is taken 5 days a week. The previous night patient ingests a capsule, and then once activated after a specific time, the next day morning patient has a bowel movement. So it is one of the things that has been tried. I'm not sure whether it is available in India right now.
Mineral water is better than our normal water because mineral water contains magnesium, so that it helps for the constipation. Another fruits you get, the kiwi fruit is and prunes, they are better for the constipation. Alkaline water I don't know. Only I don't know the mineral water because mineral water contains magnesium. That helps for constipation.
2 things, fantastic. I wish I have the slides actually, it's beautiful. 2 things I want to add. One, coffee has got some benefit, they say. Prunes and coffees as a food supplement. And I feel that this all are very costly treatment. Our patients are fed up with the costly treatment. Sometimes I give food supplements, they're very cheap and they are useful. Whether they is scientifically applicable is different matter. Since we are going to make Ayush also with allopathy, I want your thing, first point. Second, what is the role of, do you need any costly investigation before going for constipation, or EST alone is sufficient?
So regarding the first one, we always emphasize on the lifestyle modifications for the patients. We encourage them to take more amount of fiber. As Professor Barnabas sir told, and soluble fiber present in fruits like citrus fruits, prunes, kiwi, pears, all these are found to be very helpful. Guava found to be very helpful in constipation. So apart from lifestyle modifications, if the patient has not responded, only then we add the drugs. Typically we treat the patient for a month or so and then only take a decision of doing further investigations. If the patient has got alarm symptoms, obviously we are going to do a colonoscopy. And if the patient has got features of dyssynergic defecation, the first thing is to rule out that one before going to any further investigations like colonic transit and all. So first thing is alarm symptoms, colonoscopy, and the second investigation is to rule out evacuation disorder by doing a anorectal manometry and a balloon expulsion test.
So only one thing, Western toilet is prone for constipation. Indian toilet is not prone for constipation. This point has to be inoculated because Indian toilet promotes fecal passage.
Yes, sir. I think.
Google, I'm a surgeon.
Changes the angle. Western versus Indian toilet changes the angle. That's why you have now stools. So you have the commode stools coming up now to change the angle.
So many patients, even though I'm a surgeon, many with medical problems they come. Many are happy with a drug called Kayam. They are very happy. Have you heard of it?
Cheap, yes.
So the main content of Kayam is senna, which is a stimulant. So that is how it is very effective.
Gokul, that was a, sorry sir.
Carry.
Beautiful talk. That kayam also contains asafin resin of asafoetida. So asafin is a prokinetic, not only for gastroparesis, also for constipation. The other thing that I just wanted to stress upon is that motion, if you see physiologically, is formed by three things. Number one is water, fiber, but more important is bacteria, the microbiota. So even rice water in the morning with buttermilk will be a very good agent to colonize good bacteria in the gut. So probiotics also, probably supplementing probiotics also might help.
Thank you, sir.
Thank you, Gokul, for that wonderful talk.
The only one point.
Yes, sir. Yes, sir. Yes.
That is relamorelin. That is a peptide agonist of the ghrelin receptor, 1A. That also helps for the constipation. Relamorelin.
Okay.
Yes.
Thank you, sir.
So we have learned a lot more than what Gokul has told us. But it is very important to know that when you have newer drugs, there's always a spike in the use. But then you don't tell the patients what are the side effects. For example, using secretagogues causes diarrhea, prucalopride, headache, all this has to be told to the patient. They keep taking it till they have the problem, and then they stop automatically, go back to the same level. Thank you, Gokul, for that.
Thank you, sir. Thank you.
Now, I have immense pleasure in welcoming Dr. V.G. Mohan Prasad sir to give his talk. To this august audience, V.G. Mohan Prasad does not require any introduction. For the benefit of youngsters who are here, VGM is a teacher par excellence. He is one of the stalwart gastroenterologists of Tamil Nadu and probably one of the gems of Kongu Nadu. He always comes up with a catchy heading. So we are all looking forward to your talk, sir. Thank you so much.
Well, my salutations to all the professors of gastroenterology. You're all true academicians. I'm not. I'm doing a general practice in gastroenterology, but I'm really, really delighted to be here today. It's a great honor to be here standing before all of you. So my greetings to all the postgraduates. So today I wanted to speak about some funny topic, and Ravi was pulling my legs. What is this think horse? Do not forget the zebra. So he wanted to prepare and come. So he was reading all about horses and zebras. Okay, so let me move on. While hearing hoof beats, think horses and not zebras. So I'm equally confusing the two stalwart professors who are our chairpersons. So whenever you hear, like hoof beats, we always think they're horses. We don't think of zebras, but at the same time, I don't think we should forget the zebras. So this is a 35-year-old lady who came with a small polypoid lesion, which we did the EUS. Mic will have best now. Or you have a hand mic? Can I borrow a hand mic? So, yeah. Hello? Can you hear me? Yeah. Okay. So, this one, there's a small duodenal nodule. We just wanted to check what it was, where it was arising from. We found on endo ultrasound, it is just mucosal. So, we resected it and sent it, and it came as Brunner's gland hyperplasia. Then, one more small duodenal nodule. I'm sure all of us are seeing today a lot of duodenal nodules. So, again, biopsy, again, Brunner gland hyperplasia. The third one, this was biopsied, again, Brunner gland hyperplasia. And the fourth one, biopsy, hyperplastic polyp. So, this was removed. So, now, this one is a small nodule you see here. And this turned out to be, what is the diagnosis here? Postgraduates? From the histopathology, look at the bottom left. What does it show? NET. Who said NET? Postgraduates? Yeah, neuroendocrine tumor. So this is a small, little lesion in the duodenum, which is a neuroendocrine tumor, and it's a well-differentiated neuroendocrine tumor of duodenum. So this is what it is. So one more lesion here in the duodenum, again a big one, probably around 1.5 centimeters, again a neuroendocrine tumor. So what is this neuroendocrine tumor made of? The architecture is the tumor cells are arranged in nests and trabeculae and gland-like organoid patterns, and then uniform round to polygonal cells with moderate eosinophilic cytoplasm. So the salt and pepper, type of chromatin that you see is very categorical of, the neuroendocrine tumor, and you can get the fibrovascular stroma separating tumor nests, and then you should look for pleomorphism, any atypia. There are any mitosis and necrosis, and then there is an invasion. In this case, there seems to be a local infiltration to the surrounding tissue. So the synaptophysin positivity is important in immunohistochemistry. Again, chromogranin A, again in IHC is important. Then Ki67 index tells you whether it's a malignant tumor or a non-malignant tumor. With here, this is only Ki67 is below 1. So it is not it's a well-differentiated neuroendocrine tumor. You need not worry about it. Right. And this is a lecture given by Charles. This is, Karnofsky talk, where he gave a oration on Karnofsky oration, where the title was An Odyssey in the Land of Small Tumors. So this is typically the neuroendocrine tumor is an Odyssey in the land of small tumors. So it has to be remembered, it has to be looked for and not missed out. So 1907, this was classified as carcinoid. From there, now we are moved in 100 years. Now we are moved to the nomenclature of neuroendocrine tumor given by the WHO to reflect the malignant potential and also the unified biology of various neuroendocrine tumors. So, how do you differentiate carcinoid from neuroendocrine tumor? How many of you are confident? Now we have surgeons sitting here. They'll be easily they'll be able to sort out. But for the postgraduates, so older term mainly for well-differentiated, slow-growing neuroendocrine tumors. This is the modern umbrella term is a neuroendocrine tumor, and carcinoid, is largely replaced now in classification. It's usually low grade, it is indolent, and usually mid-gut, serotonin secreting tumors, and they are small bowel carcinoids. Whereas a neuroendocrine can be anywhere. It can be, well differentiated, or it can be more aggressive tumor types. It can be neuroendocrine carcinoma, and it can lie in different, organs like pancreas, stomach, or lung. So the typical carcinoid syndrome is one where the neuroendocrine tumor cells secretes the 5-hydroxytryptamine, the serotonin, and other bioactive substances which get into the bloodstream. Generally, they go through the liver and they get metabolized in the liver, so you don't develop a carcinoid syndrome features. On the other, what are the features? Flushing, diarrhea, dyspnea, palpitation, bronchospasm if it is in the lung. So generally, it doesn't happen. So, but when it enters into the blood circulation, it can produce all these symptoms. So when do you get a typical carcinoid syndrome, even if a patient has got carcinoid, is the mid-gut neuroendocrine tumor, which metastasizes to the liver, can cause carcinoid syndrome, or primary tumors outside the portal circulation, or if there is a massive tumor burden. So, like all these three situations can produce carcinoid syndrome. But how many of you have seen carcinoid syndrome? I'm sure in Chennai you should have picked up. No? Kannan? Yeah. Surgeons probably would have seen, but we physicians do not often see, very extremely rare to get a carcinoid syndrome. So, but neuroendocrine tumors are very common. So, carcinoid syndrome occurs when vasoactive substances secreted by a neuroendocrine tumor escape the hepatic metabolism and reach systemic circulation. So, how do you manage these neuroendocrine tumors in the gastrointestinal tract? If you see here, it's about 7 per 100,000 per year is the incidence, and you see the prevalence is about 170,000 in the United States, and the incidence is increasing 6.4 times. Even could be because of the PPIs and PCABs, which produce profound acid suppression, and the gastrin levels are all the time up. So neuroendocrine tumors could be attributed to these agents, and then 60% are metastatic. So if they are localized, 5-year survival is 97%. If they are regional, 91%. If they are metastatic, 58%. Right. So G1, G2, G3, and then this is menin is again this aggressive. This is a neuroendocrine neoplasia, which is aggressive type. So this is mixed type of neuroendocrine neoplasia. All these different types exist. So I'll just go through some of our data, which I collated quite some time back. 2019 to 22, we had 57 patients. 73 were male, and then 3:1 was a male-female ratio. And we had majority were in the duodenum, and then of course gastric, biliary, pancreatic, jejunal, ileal, rectal, and also esophageal. We had one in each, but extremely low in numbers. So probably this is to be updated now. So, and the incidence of neuroendocrine tumors are increasing. The lung, the colon, the small bowel, everything is going up. So pancreas, colon is sort of static but slowly rising. So now we'll go through some of those case reports. Foregut neuroendocrine tumors. A 53-year-old gentleman who came with dull upper abdominal pain of moderate intensity unrelated to food with gas trouble. So you see all these neuroendocrine tumors present with very vague symptoms. You don't ever imagine this guy will have a neuroendocrine tumor unless otherwise you start investigating, then you find. This one had multiple tiny gastric nodules and also an aphthoid erosion. We'd think, okay, aphthoid erosion could be Crohn's or something else. And you see the biopsy, I biopsied this, and you see the aphthoid erosion here, and below that is sitting a granuloma. So this is just in the lamina propria of the mucosa. So it is in the plane, just in the mucosal layer. So you see here, and these are the typical cells. So then, sometimes we get multiple gastric neuroendocrine tumors. The big one, we did endoscopic submucosal dissection. And then the smaller ones, we actually band and leave them off so that they wither off. But we just put them on surveillance follow-up protocol so that they keep checking how they are. And where there are newer tumors coming up, we can keep banding them. Sometimes in atrophic gastritis, autoimmune gastritis, these neuroendocrine tumors appear. So those will be a problematic situation. If you find a high-grade tumor, then on the background of an autoimmune atrophic gastritis, best will be to do a gastrectomy. So that is the only way to tackle these. Otherwise, in other cases, you can just follow up. This 65-year-old female who came with watery stools 5 to 7 per day since 10 years, weight loss of 15 kilos, pain and bloating postprandially. She was very poorly nourished, and multiple ulcers were seen in the gastric antrum, and also skipping the duodenal bulb, more in the D2 and D3, multiple small ulcers. So what's your diagnosis? Postgraduates? You should suspect gastrinoma. Multiple duodenal ulcers which are not in the right location of duodenal bulb, should always think of gastrinoma. So this is suspicion of gastrinoma, and of course the gastrin levels were 625, chromogranin A is 501. Here again, another rider here, if somebody is on PPIs, naturally the gastrin levels will be up and chromogranin levels will also be up. Ideal will be to take the patient off PPIs for 4 weeks, put them on H2 blockers, and then call them back for checking the chromogranin and gastrin levels. So fasting gastrin assay is important. So what we did was we removed some of these by endolooping and then allowing them to fall out. Otherwise, very difficult there to dissect. So only few people in India can do this endoscopic submucosal dissection of duodenal neuroendocrine tumors, and it has to be done very, very carefully, meticulously, slowly. Anybody can do, all of us can do, but we need time, like 2 to 2.5 hours to dissect a small 1 centimeter, 1.5 centimeter lesion. Otherwise, you can easily produce a perforation. So you have to be very slow and methodical. It's still possible. Any of us can do. So this is what we did. And then see this. This is the salt and pepper chromatin type of nuclei here. And patient was asymptomatic for 1 month and again developed diarrhea, and symptomatic she became. We did the octreotide PET CT scan at that point of time, and again persistent tumor was found in D2, D3. We suggested a Whipple's procedure, patient did not accept, and so we just did endoscopic resection. Again she did well for some time, again she developed symptoms, went for lutetium dotatate ablation, and then she was put on octreotide long-acting LAR once monthly. She became completely symptom-free, was on follow-up. She had to continue octreotide LAR. So now, gastric neuroendocrine tumors typically are 70 to 80% occur in autoimmune atrophic gastritis. Oh, this marker is not visible there. So anyway, so there are multiple small and antrum sparing generally. They can be a part of MEN1 and Zollinger-Ellison, gastric acid hypersecretion, elevated gastrin, and they could be the causes. And then multiple low metastatic potential, endoscopic resection, and of course the SSAs, the somatostatin analogs, so to reduce gastrin. So these sporadic NECs, which are more metastatic, they have if you see one neuroendocrine tumor with a high grade, differentiation with a Ki-67 index of more than 10 or 20, then these have a high propensity to metastasize. So that has to be, they are aggressive, they have to be tackled properly. So we presented, Madhura presented a poster in ACG, I think that was 2021, 23 I think. Yeah, so deep submucosal resection of duodenal neuroendocrine tumors with the Ovisco clip, a prospective single center trial, and got two poster, the best poster award and presidential poster award for this paper. And we had presented 13 cases, and they were anywhere between 1.4 centimeter median. Some were very small at 7, but majority were bigger. And male is to female was 9:2. And this is what we did. We took a 12 to 14 mm T-type OTSC clip, over the scope clip, and then deployed it and then snared on top. So this is the video. Let me see if it runs. It's not running, so it doesn't matter. So we just did the EUS, and finally, oh wow, yeah, it's running. So this is the endo-ultrasound view. Somewhere there you'll see. Sorry, I don't have a pointer here. And then we deployed the Ovisco clip. Sometimes there is difficulty in crossing the pylorus. So we just do a pyloric balloon dilatation, then take the Ovisco clip, and then suck until you get a readout, just like you treat a varix, and then you deploy. Care has to be taken so that the whole lesion is taken into the clip and not partially clipped. So sometimes one edge may be left behind. This is how it looks after giving a thorough wash. And then we take a snare and snare on top. It's just like doing a FTRD, where FTRD device very difficult to get in beyond the pylorus. And then again, for lesions which are in the anterior wall of duodenum, it's very difficult to rotate and clip it. So that is the central portion, shows a complete removal of the tumor. So these are all the cases that we did, and we could get en bloc resection 100% and R0 resection in 90.9% and deep submucosal resection in 100%. There was no bleeding, no perforation, and only throat pain because of the clip device going through, because it's quite broad. The Ki-67 index is less than 1% in 10. Only in one patient it was 2.5%. So many of these duodenal neuroendocrine tumors are benign, very slow growing, and many Americans don't even tackle it. So it's our experience also that some of these duodenal neuroendocrine tumors probably can be left behind unless otherwise they cross 1.5 to 2 centimeter size. Then we go ahead and remove them. That's one way, putting them on surveillance protocol, following them up. So this was 6 to 31 months of follow-up was presented. So this is tissue ingrowth here, but the biopsy showed negative for neuroendocrine tumor. So this yet another case, 43-year-old female with right hypochondriac pain, vague, continuous pain, 3 months, unrelated to food, and there was an echogenic lesion in the right hepatic duct, close to the confluence, with obstruction of the right hepatic duct with a dilated IHBR, as you see here, MRCP showing a soft tissue lesion of 9 to 10 centimeter causing a obstruction there, and histopathology, we did ERCP, bile aspirate, smears, all negative for cytology. So this one we did the spike cholangioscope biopsy, and again the two pathologists differed on the diagnosis. One of them said atypical nuclei, so could be malignant. So patient underwent hepatobiliary surgery, right hepatectomy, caudate lobectomy, bile duct resection, hepaticojejunostomy, and the histopathology turned out to be a well-differentiated neuroendocrine tumor. That came as a surprise to all of us, again proven by immunohistochemistry. So, and pancreatic neuroendocrine tumors are could be sometimes functional. Many of these other NETs are non-functional. So insulinomas and gastrinomas, glucagonoma, vipoma, somatostatinoma, PPoma, all these are functioning pancreatic neuroendocrine tumors, and many of them, 50 to 80% of the pancreatic nets are metastatic. So for that reason, you should look for metastasis in pancreatic nets. Midgut NETs, so 63-year-old lady presented with abdominal crampy pain, hypoechoic lesion posterior to the uncinate process of pancreas, and CCT showed mass lesion in the precaval region. So endo ultrasound was done, and this is the blue arrow shows the lesion, and we did biopsy, and this came as neuroendocrine tumor. We did the dotatate gallium DOTA PET CT scan, which showed this was a single lesion in the retroperitoneum, just adjacent to the pancreas uncinate process, and had high norepinephrine levels in the blood. So this turned out to be a retroperitoneal functional paraganglionoma. So paraganglioma that was dissected, completely resected, and then patient is on follow-up doing well. So this is yet another case, 50-year-old lady who came with wall thickening of the jejunum, abrupt narrowing and dilatation of the proximal jejunum. So we did a mini laparotomy and then took out the bowel loop. This was a dilated jejunal loop, and this a narrowed loop, and then this is the stricture there. And then this segment was dissected, and this segment was subjected to histopathology. What we found was a manic tumor. This is a mixed adeno and a neuroendocrine tumor. These are rare, but they do happen. So this patient was treated and did not require any further chemotherapy. This was a patient who came with acute appendicitis, and of course we were surprised to find that the resected specimen showed a neuroendocrine tumor. So the small bowel NETs and the so-called midgut NETs arise generally predominantly in the distal ileum. So 30% can be multifocal, and they could be serotonin secreting. So sometimes they can present as carcinoid syndrome. So that has to be remembered. So 5-hydroxy indolactic acid in urine can detect this carcinoid. And of course, the chromogranin A levels in the plasma also has to be done in all neuroendocrine tumors to confirm. Finally, we move to the hindgut neuroendocrine tumors. 68-year-old gentleman, epigastric pain, PR bleed, and this is what we found. Multiple hypoechoic lesions in both lobes of liver. Largest was 8/5. And CECT abdomen again confirmed. Query granulomatous liver disease was thought of. See, multiple, hypoechoic lesions there. And I had a distal rectal polyp. We never connected both because மொட்டை தலைக்கும் முழங்காலுக்கும் முடிச்சு போடுற கதை மாதிரி it is absolutely, we thought it's unrelated. And then the liver biopsy was suggestive of HCC. Second opinion, another pathologist said primary cholangiocarcinoma, HCCA, metastatic adenocarcinoma, hepatocellular carcinoma, all these were given. So we were totally confused. And then we did the rectal lesion. We thought, okay, we'll look at it. We did a US. It's arising from the layer 2 and 3, and then it is not infiltrating layer 4, the muscularis propria. So it was resectable. So we went ahead and did an endoscopic submucosal dissection of this almost 2 centimeter tumor in the rectum. And to our surprise, turned out to be neuroendocrine tumor. Then we took that liver biopsy and did immunohistochemistry, same lesion. The same rectal lesion had metastasized to the liver. So we went ahead and did the gallium-68 Dotonoc PET CT and then proved this and then went ahead with the treatment. So the FTRD of a colonic net can be done because it's easy to take a full thickness resection device through the rectal route but not through the oral route. It's really challenging. Even in some of these workshops, people have failed miserably because of the size and thickness. So this was again another lesion, which you can see here. The blue arrow shows the lesion, and this was dissected out. We had to do a full thickness resection here because it is involving the muscularis propria. This is where EUS comes in handy because layer 4 was involved here. So without an FTRD, we could have never treated this just with the ESD. It would not have been a complete R0 resection. So we did an R0 resection here, and which was confirmed again by the pathologist. That entire specimen was included, including the muscularis propria. So again, these are appendiceal and colorectal nets. So now, imaging and diagnosis, the next few slides, I'll quickly go through the treatment protocols and all that. It's a long lecture, but then I'll just be very brief. You can just go refer. So endoscopy, colonoscopy, capsule endoscopy, enteroscopy, all can be used in imaging. US for diagnosis wherever there is a mucosal lesion. And then of course CT MRI can detect large non-functional PNETs, may miss small insulinomas and gastrinomas, very difficult to diagnose. And then the somatostatin receptor scintigraphy and gallium dotatate. So selective venous sampling, especially for pancreatic neoplasia, if they are functional. So these are all the tests, the CG, the chromogranin A, 5-hydroxyindolestric acid, this enolase, the neuron-specific enolase, especially for neuroendocrine carcinoma, and then the NE test, which is now coming up just next to gallium dotatate. Gallium dotatate will be number 1 in specificity, sensitivity and specificity, 97 and 93%. The NET test is a liquid biopsy, not being done in India, but when it comes, probably it will overcome the need for even a dotatate. So for the postgraduates, you'll have to think of NET liquid biopsy. So please read about it. And then, of course, the imaging diagnosis. And these are all the molecular tests which can be done. So probably the molecular studies will come in future in a big way. And all these nets have to be staged, of course, very important. So these are all different, small bowel neuroendocrine tumors. If it is involving lamina propria less than 1 centimeter is T1, muscularis propria or more than 1 centimeter is T2, sub-zeros are T3, like that. All these neuroendocrine tumors. Pancreas, it is based on the size. So treatment is probably one of the best is the clarinet LAN. The blue one gives the maximum survival of 32 months. This combines lanreotide versus placebo. The other is the targeted therapy using everolimus. Again, Radiant 2 seems to be the best at 16.4 months survival, because remember, these are all aggressive tumors, sometimes metastatic, so the lifespan goes down. So we need to actively treat them. So probably the best will be clarinet, lanreotide, and then of course the everolimus plus SSA, which comes next, and then sunitinib and all have 11.4 months survival only, and then also have a lot of side effects, like you'll see the hand-foot syndrome in sunitinib. So, and then of course the peptide receptor radionuclide therapy, the PRRT, is number one, which gives the netter, you see the orange one, 48 months survival. So PRRT, here it has been combined with the SSA. So you combine both, you give a 17, lutetium dotatate by intravenous route, which homes its way, combines with the somatostatin receptors and ablates those tissues, and then you just, after 1 month of ablation, you just give the somatostatin receptor drugs, octreotide depot or lanreotide. Today lanreotide is probably better. So this combination works well. So these are all the summaries, and of course, I'm just skipping all this. Cytoreductive surgery, liver transplantation in all those metastatic lesions, and of course, ablative, interventional, and management of carcinoid syndrome, insulinoma, gastrinoma, all this I'm going to skip. But you can just read through all this in the literature. But please remember, it is a big, vast subject, so I cannot spend more time because it'll be too boring for you. The newer ones are 225 AC dotatate is coming up, and immunotherapy using pembrolizumab and combination drugs. All these are coming up in a big way. So the conclusions are that WHO 2022 grading, so Ki67 plus mitotic count, and then TNM staging are essential. Surgery remains only curative option. It can be surgical or endoscopic resection if you can get an R0 resection. Of course, the Promid and Clarinet are the first line anti-proliferative therapy, and 177 lutetium dotatate PRRT plus the SSA will be probably the best to do. So neuroendocrine tumor needs confirmation by histopathology, especially immunohistochemistry. Functional NETs respond to somatostatin analogs, like you saw in that lady with gastrinoma. And surgery is the best modality, and promising newer therapies are evolving. So while thinking of hoof beats, hearing hoof beats, think horses, but do not forget the zebra. In fact, zebra is the Singapore Neuroendocrine Society keeps zebra as its logo. So I thank my entire medical gastroenterology team, our registrars, and also the surgical gastro team at VGM, and the entire team VGM for making this presentation today possible, because a multidisciplinary, multimodality approach is of paramount importance in tackling these neuroendocrine tumors. Thank you so much once again. Thanks, Pirama, for inviting me here.
Thank you, sir, for that wonderful presentation, and thanks again for sharing your experience in managing NET tumors. It's a vast topic, and he has given you the gist. Anybody wants to contribute, sir?
So regarding the diagnosis of carcinoid syndrome, 24-hour collection of urine is very cumbersome for 5-hydroxy indole acetic acid. Now is single estimation in the serum 5-hydroxy indole acetic acid is a diagnostic of the carcinoid syndrome. And another one, lanreotide, the treatment given by lanreotide, one of the side effects is cholelithiasis. One has to remember about the incidence of gallstones. And another thing is carcinoid crisis. How will you manage carcinoid crisis during surgery? That is.
Somatostatin in infusion can prevent the carcinoid crisis, sir.
How much you give? What intervals?
3 milligram of somatostatin, continuous flow infusion, you can give it during the surgery. You can initiate even a 250 microgram bolus and then give a 3 milligram infusion. It is done under cover of somatostatin.
So in the case of insulinoma, during episodes of hypoglycemia, the drug of choice is diazoxide.
Correct. Absolutely.
Yes,
Sir.
Palani.
Sir, it was an excellent talk. I just want to share one of the clinical scenario we experienced. A 40-year-old male, he was living in US. He just flied down when he had 2 weeks diarrhea. He was from Coimbatore, and they evaluated. Somehow they did a CT, showed a periduodenal large node. So for that node, they wanted
Where was the node, sir? Where was
periduodenal, sir. Then the
Periduodenal.
periduodenal. So for some reason he came to Chennai. We did a US came as neuroendocrine tumor. Then we did an upper, to know the primary, we did an upper GI normal, colon normal, and CT didn't show anything. We did a DOTA PET. It showed only the secondary, the node alone. FDG PET also was negative. And then chromogranin was positive. And then subsequently, when we told them that this is a secondary, but the primary has to be evaluated, but he has to get back to US. So since he's known to me, he was in touch with me, and then he went to Stanford. And then there, the team told him that he has to undergo everything again. So I was a bit worried because what we missed if something comes up. And then again they did upper GA, colon, US, the same data. So then what they decided was, they planned to resect the primary, the secondary, but they have to identify the primary. So the problem was, they took him up, they did an upper GA on table, it was normal. So then the surgeon has given a note in Stanford. He called a surgeon by name Norton, who is an expert in endocrine tumor. So he was called in, he joined the surgery, and then he also palpated the duodenum. There was only a 2 millimeter nodule was there, which initially they thought it is nothing, but he said that we will as well open it and send it for frozen section. The 2 millimeter nodule was the primary.
Wow.
And then what he said was, all the secondaries, another point, the NETs has lot of unique characteristics, what sir said. The primary may be sub-millimeter. So what he said was, this can be resected, but he wanted to milk the entire bubble because there may be multiple sub-millimeter nodules. So this is what the primary was, and then they removed the secondary also. And subsequently, for the past 5 or 6 years, he is on follow-up. And another question what sir asked is, the neuroendocrine crisis, which I also have read it, come across. What the book says is, we may encounter a crisis even when we take a biopsy.
Yes.
But fortunately, I don't think any one of us have encountered. And as you said, he says, for the crisis, the patient will go in for shock immediately. No amount of fluid or vasopressor will help. It's only octreotide or what sir said, somatostatin. So what I thought at that time was we should have octreotide as a rescue measure in our endoscopy team. Fortunately, it doesn't happen. So the point is, the another case, what you said, sir, the rectal polyp with huge metastasis. That's the point what we have to understand. The primary may be very small, but the metastasis may be huge. That's the point what we have to
That is how lead tumors classically present. The primary is usually very small,
Very sub-millimeter.
but they have extensive secondaries. Thank you, Palani, for sharing your case. Thank you, sir. I think we'll close. We'll go.
Thank you so much once again.
Thank you, sir. The next is on lessons learned from the management of benign esophageal stricture by Dr. Panivel Mohan, who is a professor and head department of medical gastroenterology from JIPMER Pondicherry. Over to Pani, please.
Thank you, chairpersons. Good evening, everyone. I thank TNISG and Pirama for this invitation. So I'll be speaking on management of benign esophageal strictures, lessons learned. This will be more practical, what I learned from my teachers, from interaction with my seniors and colleagues. So the common causes of benign esophageal strictures in clinical practice are webs and rings, caustic injury to the esophagus, anastomotic strictures, post-radiation strictures, dermatological conditions including lichen planus, and peptic strictures due to gastroesophageal reflux disease. So over the last few years, there has been an increase in strictures due to eosinophilic esophagitis, and a lot of tumors, early tumors are being resected. So strictures following previous endoscopic resection or ablative therapy. So for the purpose of this talk, I have taken last 12 months of cases that we have seen at JIPMER. So we have had 245 dilation sessions in 117 patients. So the two most common cause of strictures that we see are caustic strictures and webs. Anastomotic stricture accounts for 20%, peptic strictures 16%, radiation strictures 11%, and 3% of dermatological conditions. Some of the rare cases that we have seen during the years. This is a young girl with Kindler's syndrome. It is characterized by skin blistering, photosensitivity, skin atrophy, and mucosal inflammation. These kids present with strictures in the esophagus. Usually proximal esophagus is involved. This is again an elderly woman with dysphagia and odynophagia. She's a diabetic, and on contrast esophagogram, tubular esophagus was seen on an endoscopy. Subtle concentric rings suggestive with trachealization of the esophagus with white exudates, and biopsy from the esophagus was suggestive of esophageal lichen planus. Strictures are broadly classified as simple strictures or complex strictures. Simple strictures are short, straight, focal, and they usually allow the passage of normal gastroscope. The prototype examples would be webs, rings, and peptic stricture. Whereas complex strictures are long, angulated, irregular. They are severely narrowed that they do not allow the passage of scopes, normal adult gastroscope. And the common causes of complex strictures are radiation, caustic strictures, and anastomotic strictures. The first step before one starts managing these strictures are to have a contrast esophagogram roadmap for strictures, and with the availability of thin caliber scopes and specialized endoscopes, one can characterize the stricture, know the extent of the stricture, where the stricture starts, where it ends. Without even dilatation, one can achieve all these features. So severity of strictures are graded as depending upon the passage of scope. In mild strictures, usually the standard adult gastroscope passes without resistance. In a moderate stricture, scope passes with resistance, whereas in severe strictures, normal adult gastroscope does not pass. So can I have postgraduates to try these? These are some of our patients. Contrast esophagogram, the first one on the left, can anybody say? Patient came with intermittent dysphagia for several years. So you can see, I don't have a pointer, you see a stricture here. This is a web causing severe narrowing of the esophagus. Can anybody tell what is there on the next one? So a characteristic phenomenon is described there. It's called a jet phenomenon. So when somebody has a concentric narrowing, if you do a contrast esophagogram, you see only the contrast, streaming effect of the contrast only in the center. So you mistake a stricture for a longer stricture when it is actually a short stricture. That one, anybody wants to take? You may wonder why I have put such a contrast esophagogram in a benign esophageal stricture. It is actually malignancy. Why I have put it is to emphasize the need of a contrast esophagogram or a roadmap in patients with strictures. Because we had a patient, we had an elderly patient, again, a middle-aged woman, who had dysphagia for several years. But she suddenly presented with, initially the dysphagia was intermittent. So recent onset of change in the character of dysphagia, the dysphagia became progressive. she started having difficulty in soft solids as well as liquids. That's when she came to us. So this patient has two pathologies, one in the cricopharynx, which is a web, and the second one is a tumor in the lower end of the esophagus. Another important thing is for you to have a contrast esophagogram is for small strictures or simple strictures. As you gain experience, there may a complacency may creep in that when you see a web, you may directly go in, not serially, you may choose a larger dilator, like a 15 dilator. If there are multiple strictures or if there are problems below, you may end up in producing complications. So it is always good to have a roadmap before you start your dilatation. Standard dilatation with balloon or bougie is the first line treatment for benign esophageal strictures. 80 to 90% of strictures do respond to such dilatation. Both balloons or bougies are wire guided. Balloon is designed for single use, but we tend to use them repeatedly. Whereas bougies are reusable, and a single bougie will give you only one fixed size, whereas there are balloons where you have multiple sizes available with different atmospheric pressures. The advantages of balloon are it gives you a good endoscopic visibility. Through the balloon you can visualize the stricture. Whereas for bougies, it's a tactile feel and there is no such waste obliteration that we see in balloons you see in bougies. So the last point is what I want you to focus on is where do you prefer balloon and where do you prefer bougies? Short focal strictures, we prefer balloon. Long multifocal strictures, bougies are preferred. This is very well known. But the next point is what I want you to experience in your practice. Bougies are generally good for proximal strictures and at all some mid strictures. Whereas for a distal stricture, if you want to use bougies, there are challenges when you use bougies. You don't have the tactile feel when you have a stricture lower down actually. But you have a good tactile feel when you have a stricture either in the cricopharynx or upper esophagus or up to mid esophagus. So generally short strictures, distal esophagus or mid esophagus balloons are preferred. This is again our data. If you see that ours is a center which prefers more bougies, we do more bougies. Most of our dilatations were with bougies. Some of the general tips are for wire, you can use a save-regular guide wire or a wire that is used in ERCP hydrophilic guide wire. The save-regular guide wire is a metal guide wire with a spring tip at the end. And the size of the initial dilator is decided based on your endoscopy. Target diameter varies from group. Some groups prefer 16 to 18, some groups have it 13 to 15. And rule of 3 is there for several years. But if you look at, if you actually try to find an evidence, has anybody done studies to look at this rule of 3? Rule of 3 is whenever you are doing a bougie dilatation in an adult, when you feel the resistance, the dilatation cannot progress to more than 3 dilators in increments of 1 millimeter in the same session. So this is the rule of 3. Although there is no evidence for this rule of 3. And during dilatation, we dilate to produce mucosal tears. And when you look through the endoscope, the mucosal defects appear bigger than what it is actually. And repeat dilatation is encouraged, especially in complex strictures and strictures which are refractory. Again, I want a show of hands. How many of you do bougie dilations without a bite guard? Okay, so nobody does bougie dilatation. I also don't do, but why I asked you is I'll be explaining in my subsequent slides. And here I have put different sizes of bite guards. The standard bite guard that is used in most of the endoscopy units is 48 French. Let me tell you, like what we use in our unit is a 60 French bite guard. I'll tell you the reason behind that. Ideally, mouth guard or bite guard should be removed for dilation. This is because if you have a bite guard, the dilator enters into the oral cavity or oral mucosa perpendicular to posterior pharyngeal wall. So if it enters the posterior pharyngeal wall perpendicularly, it has to take a 90-degree turn to enter into the hypopharynx. The sharp turn increases the risk of pain, contusion, or crush injury. This is especially true if you use a large size dilator. Once you cross 10 millimeter dilator, dilators are available from 5 millimeters to 20 millimeters, bougies especially. So you have to remove the mouthpiece. This is what is advocated. Dilator is moved to a shaft. Dilator shaft is moved to one corner of the mouth, and the extra oral segment of the dilator is elevated. Why should it be elevated? Because this elevation will bring the axis of the dilator parallel to hypopharyngeal lumen. And second thing is, from the hypopharynx to the stricture, there is something called in-axis orientation, which can be achieved only with whatever manners I have described. So why we don't remove the bite guards? Because most of the dilatations that we do are without sedation. So what we do is, we use a larger size dilator, 60 French dilator, through a 48 French bite guard to pass a 15 millimeter dilator. You have resistance at the bite guard itself. So for an operator to appreciate the true stricture resistance, rather than the angulated resistance that they feel at the posterior pharyngeal wall, this we practically felt in our patients. So you may not actually, because when you do endoscopy and see, sometimes you don't even have mucosal injury when you have resistance in the hypopharynx. I hope you are getting what I'm trying to explain. So this picture or slide actually shows you, this is the metallic guide wire, spring metallic guide wire, savory gillette guide wire, which has a spring tip, and it has markings, and each black marking represents 20 centimeters from the tip. So if you have 3 black things, as we have here, it is 60 centimeters from the tip. Fluoroscopy is recommended for a safe and an effective stricture dilatation in the esophagus. So you need fluoroscopy to look at the position of the wire, position of the dilator when you do dilatation. Otherwise, what happens is they are at risk of bleeding and perforation. So if a unit does not have fluoroscopy, or if they want to do a dilatation without fluoroscopy, can it be done safely? This is what we described. Actually, this is Ravi sir's case report, which I published when I was a postgraduate. Even today, I follow this one, that we ensure a constant length of the guide wire. Once you place a guide wire and an endoscopy or fluoroscopy, like if you don't have a fluoroscopy, see a stricture, pass the guide wire into the stomach as deep as possible. If you use a savory gillette guide wire, you will know at what centimeter it is at the bite guard. The tip of the metallic guide wire should be fixed to a particular point in the room, so that when you do repeated exchanges, the tip of the wire should neither move in nor move out to the reference point. So which ensures that the guide wire, tip of the guide wire is in the stomach, deep in the stomach. Again, this is one more lesson that I would say that is very important is, medical gastroenterologists, we see a lot of cases referred for dilation after surgery, anastomotic stricture. It's very important for us to know the anatomy. So here is one patient who had surgery for corrosive. So surgery for corrosive, either a stomach is used as a conduit or a colon is used as a conduit. So when a colon is used as a conduit, the esophagus is excluded. So when the esophagus is excluded, if it's not transected, at the colo-esophageal anastomosis, there can be 2 openings. Like for example, this is a patient who came with anastomotic stricture. The esophagocolic anastomosis got strictured, but the esophageal opening, the excluded esophageal opening had opened. So when we pass the guide wire, it is important for us to know where the guide wire goes. In a native esophagus is anterior to spine. So if you see the passage of wire anterior to spine, it is going into the excluded esophagus. Whereas all these conduits which are constructed, they are all retrosternal or anterior. So if you see the wire moving anteriorly, then it means that you are in the right track. So you will be dilating the track which you are supposed to dilate. So it is important for a gastroenterologist to understand the anatomy, various surgeries that are being done, and what you are dealing with. So what about the literature comparing balloon and bougie? There is a systematic review, good systematic review, meta-analysis of 5 RCTs including 461 patients. There is no difference with regards to symptom relief, recurrence or severe complications. But it's less post-procedure pain is seen with dilation, with balloon dilation. Recurrent strictures or refractory strictures cause anatomic restriction because of luminal compromise or fibrosis in the absence of inflammation. So the accepted definition is refractory strictures, patients in whom you are not able to achieve a diameter of 14 millimeter when you do dilatation sessions once in 2 weeks, at least at the end of 5 sessions, you're not able to achieve a diameter of 14, it is refractory. Suppose in patients you achieve 14 millimeters, but you are not able to maintain 14 millimeters at the end of 4 weeks, then it is recurrent. So what does the literature say on refractory benign esophageal strictures outcome? This is a good study published a couple of years back, at least a decade back, from the Italian group, 70 patients with close to 4 years of follow-up. They had different etiologies of strictures, and the median number of dilatation sessions required was 15. So if you look at this data, only 1/3 of patients with refractory strictures where they were able to manage with repeated dilatations. So this is our data. The last 1 year, whatever I told you, 245 dilation sessions. If you look at our data, webs and peptic strictures require 1 session or at the maximum 2 sessions. They are simple strictures, they can be easily managed. But if you look at the other strictures, like caustic strictures, almost 2/3 of them required multiple sessions of dilation. Similarly, anastomotic stricture and post-radiation strictures. This is again one of the retrospective studies that we did looking at, although webs do have good response to dilation, we saw some of the patients coming back with dysphagia. So we wanted to look at, is there anything that predicts recurrence of dysphagia in patients who undergo dilatation for webs? And we found that if the initial diameter of dilation was less than 13 millimeters, and people who fulfill the criteria of Plummer-Vinson syndrome, and in whom iron deficiency anemia is there and they don't have correction of iron deficiency anemia, we see them come back with recurrence. So, and this is actually our data in the last 1 year on children with benign esophageal stricture, 14 children undergoing total of 24 dilation sessions. If you look at the etiology of benign esophageal strictures in children, based on the age group, less than 10 years of age, anastomotic stricture is the common cause of stricture, whereas more than 10, caustic supersedes anastomotic stricture. And again, in pediatric, we prefer bougies to balloon. So what are the tools available to a gastroenterologist when they are managing strictures in children? See, many times in children, you can pass only the wire. You may not be able to pass anything beyond that. For example, if you want to do a balloon dilatation, even the balloon catheter will not go. So in those situations, we can use Sohendra biliary dilators. So if you use an adult gastroscope, you can pass maximum of 7 French Sohendra. But what we do is we use through the scope up to 7 and then remove the scope, and over the wire we use 8.5 French and 10 French, and then we proceed for balloon or bigger dilators. Again, ultra slim and pediatric scopes help in characterization of the stricture. Biliary SEMS we have used in few cases in pediatric strictures. So the challenge is, how much is the ideal diameter in children? Nobody knows actually. The literature is also divided. If you look at large data that has come from SGPGA pediatric gastroenterology group, any child up less than 2 years of age, they have kept the target diameter of 11 millimeters. 2 to 5 years, they have kept it as 12 millimeters. And more than 5 years, they have kept a diameter of 15 millimeters. But having said that, we are really like worried to go beyond 12 millimeters in children actually. So this is one child where this child had TEF. The child had undergone 3 surgeries. First, stomach was used as a conduit. It did not work. Then jejunum was used. These surgeries were done outside, and the child came to pediatric surgery in Jipmer. And they, pediatric surgeons used colon. And this child had 3.5 centimeter long stricture. It was an angulated stricture. We could hardly pass a 8 millimeter dilator or a bougie. So in this child, we tried biliary stems. Biliary stems worked very well. I was discussing with Ravi sir for this management of this child. But subsequently, what happened after removing the stent? This we did after 8 weeks. After removing the stricture, again recurred. So what we subsequently we did was we went for a larger size of stent, customized stent from Konyo. It's a Korean stent where proximal flare is there. We could get 16 millimeter, 14 millimeter with those stents. And the child is doing well. Still the child is having the stent actually. We have not removed it. So this is again another child. TEF repair, we did dilatation. Post-surgery, the child required few dilatation sessions. Then the child was okay. At 1.5 years, the child came with food bolus impaction. So when we did, there was a seed, we could retrieve the seed. The importance of patient-reported outcome, which I will be discussing in my subsequent slides, are many times we treat patients, gastroenterologists treat patients, surgeons treat patients for strictures. We think or we assume that our patients are doing well, but we really do not know, has the patient gone back to the same as what the patient was before, or at least 70% to what they were before. Many times, at least in public sector, patients only come when they have severe symptoms. Like they modify their diet. If you ask them, do you have any dysphagia or do you have any problems with eating? They will say no. But if you ask them, how long do they take to complete a meal? They will say half an hour, 45 minutes, 1 hour. They can't sit with in a public with other friends and family and finish off the meal. And they will start avoiding particular foodstuffs. Like if you ask them many things that they will experience choking or with some foodstuffs which they will avoid. So even after dilatation, even after surgery, if you see these children or adults, have they gone back to normal? Many times it is no actually. And there are some challenges if you see dermatological conditions while you manage strictures. We had the experience of managing 2 cases of epidermolysis bullosa. I have taken from the literature epidermolysis bullosa. This is the largest data available in the literature from Great Ormond Street, 223 children with epidermolysis bullosa. It is a severe blisterizing disease involving the skin and the mucosa. There are different varieties, the simplex variety, junctional variety, and a dystrophic epidermolysis bullosa. We saw an adult with a dystrophic epidermolysis bullosa. So the important challenges are these adult or children, because of repeated oral trauma, they have a limited mouth opening, fixation of tongue and epiglottis. The choice of dilator is, if you use bougies, you have a longitudinal force or an axial force. The injury across the esophagus will be more. So wherever injury happens, there will be scarring and there will be more problems that can happen in these patients. In these patients, what we had, like, and I can tell you, so this is one adult patient who had a proximal stricture. The stricture was pinpoint. Actually, when we did the stricture, like initial dilatation, we could do only 9 millimeters. After dilation, in the subsequent session, patient came back with complete occlusion of the lumen. We could not pass any wire. So this patient had to undergo gastrostomy. Through the gastrostomy, we attempted retrograde dilatation in this patient, which was again unsuccessful. This patient finally ended up in surgery. So This is a really challenging situation, epidermolysis bullosa, particularly a severe cicatrizing form of epidermolysis bullosa. The goal is avoid trauma to the skin and mucosa as much as possible actually. The strictures here are single proximal stricture which are characteristic, and we have to ensure that lesser radial force or lesser time of dilation is required. And many times you tend to end up doing antegrade as well as retrograde dilatation for these patients. Some of the corrosive strictures, retrograde approach is done through using an ultra slim scope through gastrostomy. And bidirectional scopy can be done. If transillumination is possible, you can use needle life to puncture and dilate subsequently. So in patients where strictures are refractory, where it is challenging, steroids are advocated. Triamcinolone is used. It is 40 milligram, available as 40 milligram per ml. It is diluted as 1:1 equal normal saline, and 0.5 ml is used into the stricture or in 4 quadrants. Maximum of 3 sessions can be used. It's most useful for peptic strictures. Incisional therapy, I have not done, but it's given in the literature, like at least for short strictures, anastomotic strictures, a needle knife cauteries with a pure cutting current can be used. 4 to 8 radial incisions are made, and it can be followed with a balloon dilatation. So stents are increasingly used as a last resort in benign esophageal stricture. Here the dilating force is left in place for weeks. Results are mixed with a clinical success of 40 to 50%, migration rates of 30%, and an adverse event of 20%. So before planning stenting in strictures, thoroughly study the imaging that you have. Use slim scopes to define the stricture, proximal extent and the distal end of the stricture, and choose 4 centimeters, 2 centimeters on either side to the length of the stricture. The problem with placing stents is the fully covered stents are used, they migrate. So if you can use some way of fixing the stents, there are special fixation devices that are available now, over the scope clip specially meant for fixing stents, so that you can reduce the migration and increase the effective dilation time for strictures to be remodeled. So these are, like in the last year, we have done close to 6 patients SEMS. We have a success rate of 50%. Like, I can't say it's number 6 percentage and all. 3 of them we were able to reduce the number of dilation sessions, and also the dysphagia score also improved in them. So here's a patient who had a self-expandable metallic stent, but what happened is the stricture got remodeled and there was a migration of the stent. So here I have not used over the scope clip, I have used hemostatic clips in this patient. So here is a systematic review comparing SEMS, lumen opposing stents and biodegradable stents. Technical success is the same with all the 3 type of stents. Clinical success, if you look, it is somewhere in around 50%. LAMPS is used for a short stricture, and statistically the outcomes are better. So this is again self-dilatation, a concept that is actually taught to patients with corrosive stricture. Not much data is there. There's one largest reported series wherein they compared physician dilatation and self-dilatation, follow-up of 3 years. And it has to be taught to patients under supervision. And ideal or a desirable dilator would be not more than 15 millimeters. And literature also says use of a chemotherapeutic agent mitomycin C. I also don't have any evidence. I don't have any experience. And some literature in children supports the use of mitomycin in strictures. So this is again from our experience. We have a largest cohort of patients with Plummer-Vinson syndrome. So from 2013 to 2020, we had 170 patients, and 146 of them fulfilled the criteria of Plummer-Vinson syndrome. In them, 9 of them had esophageal malignancy. 6 of them had concurrent malignancy. Like when they presented, they had both webs and tumors. Whereas 3 of them, they developed malignancy during the follow-up with us. So when we did dilatation, they went home, and after few years later, 3 to 5 years, they came back with worsening dysphagia. Some interesting findings, what we noted is in these 9 patients, 6 patients had some form of lichen planus. Lichen planus again is a pre-malignant condition. Oral lichen planus has got a propensity to develop squamous cell carcinoma. And human papilloma virus, 16 and 18, particularly in regions which are endemic for high esophageal prevalence, there is an association between HPV and lichen planus. So we really did not know, actually. This is proof of concept where we don't know whether lichen planus, Plummer-Vinson syndrome, and human papillomavirus, is there any relationship between these 3? So this was what I was alluding to my earlier slide. Patient reported outcome is there for disease, is there for symptoms. We need to look more into patient reported outcomes for dysphagia and for benign esophageal strictures. So I conclude my talk with this algorithm. So this algorithm is like you can customize it depending upon what you have in your clinical practice. Thank you.
Thank you, Palani, for that wonderful talk. Just a few observations from my experience. I think we have a lot of junior postgraduates here. I think one should not attempt a dilatation without a fluoroscopy. That's rule number 1. And using metal guide wire for esophageal dilatation is a little bit of a problem, because after the first dilatation, it starts kinking. Then you're not able to pass the dilator. I think we overcome it by using the biliary guide wire. It works as well. You don't have the problem of kinking. And then it is always better to dilate under fluoroscopic control. If you do serial dilatations, I teach my postgraduates to make sure that when you use the next dilatation, make sure the guide wire is in the stomach, beyond the stricture. Because we've had experience, I think we asked the postgraduates to dilate, they didn't check the guide wire, they pushed the second dilator, and then we had a large submucosal flap which we had to clip. And it's all avoidable. So no dilatation should be attempted without a fluoroscopy unit being available. And his point is well taken when he says you dilate a CP web and send them home, you miss the esophageal cancer. It's happened to us a lot of times. So whenever you have anemia, Plummer-Wilson, CP web, dilate and make sure you complete the endoscopy to make sure the rest of the esophagus is normal. I think this is now the dictum everywhere. It has been a wonderful talk and nicely covered. I think Kannan has got a lot of experience in self-dilatation. I think he did a lot of esophageal surgeries and then he used to teach his patients to self-dilate to prevent esophageal stricture. You want to talk something, Kannan?
Actually, this self-dilatation is very useful in high pharyngeal strictures. You know, we do the anastomosis high in the pharynx. So these patients are able to self-dilate easily. You know, I asked them, I used to, when I was in government studies, now I don't have the opportunity. They used to come to our department. They used to pass the bougies themselves. Slowly. And regarding the postgraduate web, what I do, I ask the patients to swallow a Foley's catheter, inflate the bulb, and then remove it. That is painful, very painful. Not very painful. Foley's catheter is not very painful. 10 ml distilled water or air they inject, and somebody, relatives, pull it out by force, and monitor the esophagus frequently with endoscopy. That is another self-dilatation I try.
They become very intelligent
Many times, patients who have had caustic injury to the esophagus, they come to hospital several times. After surgery, when the lumen also, they will guide you. When you pass the wire, they will tell you whether it is going into the lumen or not. So they are intelligent that they can actually do those things if trained. It's better for a proximal stricture, better for a simple stricture, because if it is angulated, it will be difficult for them to do it actually.
Now I do it for post-anastomotic stricture. Proximal anastomosis I do. You know, we have been in Stanley, we have done a lot of dilatations. I have perforated esophagus many times with the guide wires rather than the bougies.
And one more thing is regarding the web, the other method of dilatation, because we have seen lot of webs, we have used balloons in patients with web. There are different kinds of webs which we have seen over the years. Some webs are thin, mucosal. They are seen only from one wall, anterior wall of the esophagus. Some webs are at multiple levels. Some webs are concentric. Some webs are thick. So if you use balloons in patients with thick web and concentric web, when you inflate the balloon, it just compresses the web. And once you take the balloon out, you won't be able to again pass the endoscope. So in those patients, what we have seen is if we use dilator and rupture, that's bougies are the best for those webs. So not all webs are same is what we have actually. So that's why we use generally bougies for most of the things, because we are comfortable and we have the feel actually.
So I thought I'll have 3 points to you. One is, I think I'm in agreement. I'm in agreement with him that flora is essential. Otherwise, we'll be missing it and we'll be creating a complication. That's number one. If you don't have a fluoro, please don't do it. That's the thing. And second thing is, like, I have done probably around the 50% of the numbers you have told over a period of this 22 years. And probably in only one patient, I had to use a dilator. I had to use a dilator. In all the other patients, with the appropriate direction of the pressure and a gentle push, we are able to tear the web and then go past beyond that. Sometimes we may not even see. There may be some resistance, we'll go past. When you come back, the same place, if you concentrate, you can see some blood coming, you can see the membrane there. There is an indication. Third one is, we have been taught, even in my exam, there was a question, you share it open. That's the policy, but it's not like that. Because some strictures are very tight, some strictures are very, very lax. So it's good to dilate to the pressure which releases the waste and makes it disappear. To that extent should be all right in any stricture for that matter.
Regards to the first comment that I am not advocating fluoroscopy dilatation without fluoroscopy. I have been telling, like, in this 20 years of endoscopy, there have been periods in which we have dilated without using fluoroscopy. I no more do dilatation without fluoroscopy. I will not advocate, but I am just telling, like, if at all somebody is confronted with situation, sir says don't do it, that will be the best thing. The second thing is, sir told about this webs. See, what we have, like, with this data of 10, 12 years of webs, we have tried to look into the questionnaires, symptom questionnaires in patients with web. So in patients who have webs, who have undergone different types of like scope rupture or balloons or bougies, if you go and talk to the patients, invariably before diagnosis of webs, most of the patients will give one history, which is, for any other reason, if they have to take a pill, they won't be able to swallow the tablet as a whole. Most of these patients will powder, will actually make it into multiple pieces and take it. So if our dilatation is incomplete, still patients won't take, because once it gets stuck there, the feeling that they have, the choking feeling, that is why they avoid. We actually came up with a 3-point questionnaire, with 1 point being tablet dysphagia or difficulty in swallowing tablet, inability to swallow tablet as a whole, points the time of origin of web. Many times, patients come with intermittent dysphagia for several years, but when they come with more symptoms, severe symptoms. If you ask them, they tell that since 15 years, I have never been for respiratory infection or for when I have to take a tablet. It's never happened. And they also say for some nuts, if they eat hurriedly, it gets blocked there. So they have to bring it out and take. So we also indirectly assess our success of dilatation based on what kind of food they are able to take after dilation. So
extend like this, have something, and then they do like this. Without this pressure, they won't be able to push it down. That's number one. The duration of time that they take to complete eating is nearly 3 times the next person. நான் இது என்ன கேட்குறேன்னாக்கா, கல்யாணத்துக்கு போனீங்கன்னா பக்கத்தில் இருக்கிறவங்க அதே நேரத்தில் எந்திரிச்சு வந்துடுவீங்கன்னா முடியாது. They don't even... Yeah, one more point only, sir. And second, you don't need to wait longer. Once you do a successful dilatation, when they come out, ask them to swallow water. It will be like going in a Vajpayee national highways. They will feel so free. That itself is an indicator.
The use of bougie caps. Ovasco has these bougie caps, for direct endoscopic dilatations.
I don't have any experience with bougie caps.
Well, I have tried in some patients, and you can actually do a very good dilatation using these bougie caps under direct endoscopic vision if at all you don't have fluoroscopy. So.
Yes, ARV.
I agree with everything. Only thing I am not comfortable with the SEM. Actually, some of the people who have come from Medindia, they will agree. Chandrasekhar, myself, and others in Thoothukudi, we have experienced that the SEM impacted. It needed surgery. For a benign stricture, SEM will be the fourth option. Mitomycin C, MMC had some experience. Of course, we have done in 2004 itself, we did the triamcinolone. The excision is okay. But SEM, be cautious. We needed surgery to remove the SEM. Myself, TSC, others, they have experienced this point. That's why I wanted to make this point. I normally give them. In 3 days' time, the pain disappears. Then they take normally. So even after 3 years, if they stop replacement with iron, the web tends to recur. That's again important.
Nice lecture, Pani. I think one thing in children is especially very scared of using first time you will be and pass the endoscope, they can check for the lighter weekly sessions. There have been some of the conditions like zero maybe right away a child with chronic not using the success rate is very fantastic.
Thank you.
Thank you, Dr. Pranil, for inciting a good discussion. I think so much to discuss. Probably we can do it while we have dinner. So this is time to thank you all. Dear colleagues, senior consultant, experts, I would like to thank the chairpersons and the speakers, and particularly the postgraduates, Dr. CB, Niroj, Dr. Arvind, who had very good case presentation. We learned a lot from you guys. And thanks Dr. Mohan Prasad, Dr. Gogul, and Dr. Pranil Mohan to present in the CME. I would like to thank MSN for providing the place and for the dinner. And it's a time that we can part, but you all know that tomorrow we have an Crohn's Colitis Foundation TN chapter. We have very good speakers from all over India. So please make you available to attend the meeting. And thank you once again. We'll meet you tomorrow morning, 9 o'clock. Thank you.